Well, hello, everyone. We are live now. So welcome, welcome, welcome. I encourage you to, in the chat option on the right-hand side of your screen, we'd love to know, where you're from to see who's attending. I am Bridget Wallace. I'm a physical therapist. I have a clinic in Austin, Texas. I've had this clinic for over 20 years now, and I'm also the co-founder and clinical director for 360Neuro. So we're bringing you this exciting webinar with Dr. Gianoli. So welcome, Dr. Gianoli. Dr. Gianoli is a board-certified neurologist, as well as with the head and neck surgery, and practice is in Covington, Louisiana. How long have you been there?
In this particular location, about 12 going on 13 years, but in southern Louisiana, I've been here 30 years or so.
Well, great. I am going to keep the introduction to you fairly short because you have quite the resume. Many publications I've been following your work for a long time. You've also written chapters, and now the reason what brings us here today is this fantastic book that you released, Third Mobile Window Syndrome of the Inner Ear. And I can't wait to this. I mean, really, this book had me hooked from the very beginning, and I could spend all day talking about it. So it is definitely an honor to have you here.
Thank you so much. Pleasure to be here.
And, so I'd like to say, just to our listeners, I do love to start out on a personal note. And the personal note that you and I share is that this book is, and I don't know, I might get a little teary-eyed. I'll try not to, is that this book is dedicated to Dr. Swallow, who I had the honor of meeting in the late 1900s. Oh my gosh, I am older than I thought. The late 1990s, and we were brought together to do a lecture series across the South on how to build a balance center. And he just, in this book, just as you said, he became a mentor, role model, and friend. And he is missed dearly. So I'm glad that meeting him allowed our paths to cross.
Yeah, Jim Swallow has a very special place in my heart. Besides being my business partner for close to 23 years, one of my best friends and a mentor to me as well. But I really think Jim Swallow is one of the most unheralded people in the world of vestibular medicine. There's a lot of things that we do and see with testing and stuff that his fingerprints are on. Even though you will never hear his name, he was heavily involved in the testing industry, beta tested a bunch of the devices that you're all currently using, and the improvements based on his input is all built into those pieces of equipment.
Yeah, and he brought one of our audiologists, who has since retired, Brad Melanson, and they worked together, kind of first audiology physician to come together at LSU Medical School and create this balance center concept. And they both used to love to tell me how they, on a V&G, it was like EKG strips, and how they would do things by hand. And so a true pioneer. And I just could have thanked him enough. And so I'm going to let his spirit live vicariously through you and your brain. So we'll go ahead and get started. Thank you again for joining us. And please, I'll be monitoring the chat. If you look over on the right-hand side, there is a button for chat and for Q&A. It is easier for me to follow if you just go ahead and put your questions, your comments in chat. And then we've already received some questions ahead of time that I'll be going through at the end. But I personally have some questions that I would love to ask Dr. Gianoli about his book. And again, this is the third mobile window syndrome of the inner ear, and really, encouraging us to look beyond the terminology of superior canal dehiscence. So, as well, I think, before we get started, what I hadn't mentioned, Dr. Gianoli, is the co-editor of this book. So why don't you share to our listeners kind of how this book even became about?
Sure, it's an interesting story. My co-editor is actually a patient of mine, Philippa Thompson. She is a lady who came to see me in year 2009 with the suspicion of superior canal dehiscence bilaterally. She had undergone a surgery in the UK that didn't go so well, and she got really knocked around the system, told she was crazy, and in fairness, this was early on in the whole evolution of superior canal dehiscence, where wasn't a lot of physicians, even among neurologists, that aware of the disorder. So she came to see me in the year 2009, and eventually I wound up doing surgery on both of her ears, and she got a great result. She then published a book of her memoirs, and I thought I'd show this to the crowd. This is her book. It's called The Hole in My Life, and I think this was done about 5 or 6 years or so ago. And this was her memoirs of her going through superior canal dehiscence. As a little side note, when I have a patient who comes in who's got superior canal dehiscence or some other third mobile window syndrome, I give them a copy of this book. And the reason I give you this book is a couple of things. One is she does a great job. She's a great writer. She does a great job explaining the disorder in layman's terms. It gives you an idea that you're not alone. There's other people that have this problem. And I also think it's a good thing to give to loved ones so they can understand what's going on. As we all know, in dealing with patients with vestibular disorders, it's not like you've got a broken arm and a cast you can wear and people can sign on it. It's in your head, and they don't understand it, and they can't understand why it's not something you just don't get over. And of course, the other thing I really like about this book is I star in the second half of it. So that's really
I love it.
So in any event, after she had her surgery, she decided she was going to make superior canal dehiscence, letting everybody know about it, one of her life goals. She went back and got a master's in science degree and started writing articles about her situation and trying to publicize it. And then she eventually submits the book, textbook idea to Springer Publishers. And she got an immediate response from the publisher saying, absolutely, we want to do this book. There's nothing out there like it. And her response was, fine, but Dr. Gianoli's got to be the editor. And so she emailed me the next day. And the thing was, it's something I've been planning on doing for a while. And when she came to me with this, it's like, oh, of course. And so we then put together an outline, and I have 66 authors for 30 chapters, and the authors from literally all over the world. And within a year, we got the whole book together.
All right. Well, before I go on, someone's asked if you could just hold the book up again. And I think this is a book we need to buy and introduce to for some giveaways. And Jill, if you can read it, it's A Hole in My Life is the actual title of the book. All right. Well,
Philippa Thompson's the author.
I took notes to keep myself on track so that I would keep you in this reasonable time. So I think one place I would like to start, Dr. Gianoli, is just, in chapter 1, it starts off, and I think that first sentence talking about third mobile window syndrome and otic capsule dehiscence syndrome. And that may be some acronyms or some terminology that our listeners aren't as familiar with. So can you expand on versus superior canal dehiscence?
Sure. So superior canal dehiscence is just one type of third mobile window disorder, or one type of otic capsule dehiscence syndrome. And it's the one that's been most publicized. It's the one that's been written about the most, but it's not the only one. And in fact, I would argue it is not even the most common one. Cochlear facial dehiscence, which is another type of one, is actually probably more common. It's just not recognized near as much. It's more difficult to identify for certainty on a CAT scan than superior canal dehiscence is. But in anatomic studies, it's more common than superior canal dehiscence. There's other ones. There's dehiscence of the posterior canal. You can have it dehiscence adjacent to the posterior fossa dura, adjacent to the internal jugular vein or jugular bulb. You can see it dehiscent into the vestibular aqueduct. There's horizontal canal dehiscence that we can see. That one has been identified, way back when cholesteatomas would erode into them, and they could present with a very similar syndrome as superior canal dehiscence. But there's also an anatomic dehiscence in some folks where the horizontal facial nerve goes over the horizontal semicircular canal. And that's something we just published this past year that is probably more common than we realize. So I guess one of the big things I wanted to let people know is not only are there other types of third mobile window disorders besides superior canal dehiscence, it's also not rare. And, in my field, if you go on the, I guess it's the CDC or NIH website, though, and you look up superior canal dehiscence, they call it a rare disorder. It is not a rare disorder. A rare disorder has actually got a very specific definition. It's a condition that afflicts less than 0.06% of the population. Well, we know from anatomic studies, 0.5% have superior canal dehiscence, and another 1.5% have extreme thinning of the superior canal to the point where it can give them a functional dehiscence. So we're talking about 2% of the population almost. And that's just superior canal dehiscence. Doesn't include cochlear facial dehiscence, posterior canal dehiscence, horizontal canal dehiscence, cochlear parotid dehiscence, on and on and on, to the point where, probably a large number of our chronic dizzy patients fall into this category.
Yeah, I think if I recall correctly, it had mentioned 15 known sites for a high resolution CT scan, but yet more that could not be recognized. And I think, I recently attended the American Balance Society conference, and it was presented there looking at audiograms and VIMPs. Not everyone, the high resolution didn't support the diagnosis. And someone, I remember, actually it was Cameron Barine, said, well, maybe we shouldn't have the diagnostic criteria from a high resolution CT scan. Maybe we should be doing symptoms and VHIT and VIMP. Maybe it's the high res missing it. What are your 2 cents on that?
Well, I think that's an excellent point. And Cameron Barine is a very smart guy, tops in the field, and I think he makes an excellent point. But if you add on top of that the condition called near dehiscence, okay, where the bone is very, very thin. The analogy I give to patients is bone is like wood. When it's thick, it's nice and solid. But when it's really thin, it's like a piece of paper, and it can transmit pressure. And so consequently, when is it too thin? And I think the way to look at it is exactly like Dr. Barine said. It's, what does the physiology look like? So if you want my personal opinion on third mobile window syndrome, first of all, syndrome is a collection of symptoms. It doesn't even go into diagnostic testing. So third mobile window syndrome is one thing. And there's a lot of folks that'll have third mobile window syndrome that do not have any identifiable anatomic dehiscence on a CAT scan. And it doesn't mean they don't have the problem. It just means you can't find where that dehiscence is anatomically. Some of those folks have near dehiscence, like maybe they've got bone intact over their superior canal, but it is the cause of the problem. Some of them, it's probably a dehiscence that you just can't identify or haven't looked for. And this is something that became very apparent to me early on in my career when I was one of the only people taking care of superior canal dehiscence. I'd have a ton of patients show up saying, look, I've got autophony, I hear my heartbeat in my ear, I strain, I get dizzy, certain sounds make me dizzy. They've got the whole ball of wax of third mobile window or superior canal dehiscence symptoms, but they don't have a superior canal dehiscence. And I would test them, and they'd have a positive fistula test, and they'd have a positive Valsalva test. And we early on we weren't doing VIMS, but you get the idea. They have physiologically, they look like that. So then I started looking. They've got to have a dehiscence somewhere, and some of those folks had posterior canal dehiscences. Some had dehiscences in other spots, and then the kind of catch-all I would throw out there is, if you can't find a dehiscence spot, you have to wonder about an oval or round window perilymphatic fistula, because they generally respond to treatment as if they had an oval or round window fistula.
All right. And, I want to point out here, because I had this burning question in the beginning and thought that all my questions would interfere with the time. So I want to thank you, Sheila. Oh, she just said you answered her question, but it was, would the other symptoms, and I was curious when you said horizontal canal, or when I read about the facial, is there anything unique or different that they may present with than we would expect as compared to superior canal dehiscence?
Sure, yeah. So for cochlear facial dehiscence, one of the things that's kind of unique, that's a little different, is they tend to have a notch in their hearing around 1 to 2,000 hertz. Sometimes it's a conductive notch, sometimes not, and it doesn't always happen. But when you see that, and they've anatomically got it, and they have the symptoms that go along with it, it raises my suspicion that they really do have a cochlear facial dehiscence. I'm reminded of a patient I saw recently who, he actually was deaf, and he had cochlear implants placed bilaterally because of his deafness. He gets in a car accident. Afterwards, he is so dizzy, and the main thing that makes him dizzy, straining. But he also gets dizzy with certain sounds. Mm-hmm. And he was not getting dizzy before the car accident. We work him up, he's got, I don't remember what his VEMPs were, but he had a very positive Valsalva test, which is consistent with a third mobile window syndrome. And on his CT scan, he had very large bilateral cochlear facial dehiscences. So I'm curious, and I start looking back, what did this guy's hearing look like way back when? And sure enough, I had his old records. You go back to the beginning, he's got this notch at 1,000 hertz, and that was where his hearing was the worst. And it just kind of progressed from there over the years. He also had sleep apnea too, by the way.
So is the notch, can it be bilateral? So does it look like a trauma notch on the high end, but it's on the 1,000 to 2,000?
Yeah, it's not too dissimilar from what you'd see with a shooter's notch or noise notch that you typically see at 4,000 hertz. Again, it's not a guaranteed thing you're going to see. And the interesting thing is sometimes it's a conductive gap or a conductive loss rather than sensory neural.
Okay, all right. Thank you. That answered actually the other questions that I had wanted to ask. And so in chapter 5, it talks about third mobile window disorders being the great otologic mimicker, which I thought was really great. Are there certain other disorders, where do you find this to be more challenging, or is it just, it's all more challenging? But I'd love for you to elaborate a little bit more, just briefly on that chapter.
Well, I wish I could take credit for the name, the great otologic mimicker, but that was Dennis Poe and his group came out with an article basically saying, hey, it can look like patchless eustachian tube, it can look like otosclerosis, it can look like Meniere's disease, on and on and on. And which leads to one of the sticky things with my field. Depending on what part of a patient's history and symptoms you emphasize, you can make things sound a lot more like one thing versus another. And if they've got a headache, you can always say it's migraine. But probably, at least from Dennis's standpoint, the big one was patchless eustachian tube, because Dennis is, Mr. Eustachian tube surgeon, and he gets a lot of folks sent up for patchless eustachian tubes. And so he made the correlation, hey, they don't have patulous eustachian tube. They've got something else. Now, of course, the problem comes in, what if they have both of these problems? Mm-hmm. And I've seen patients who've got superior canal dehiscence for sure, and they also have patulous eustachian tube. And, probably the biggest thing you have to do with those folk is kind of educate them what part of their symptom complex is coming from which disorder, and try to help figure out what's most important for the patient to get better. Sometimes it's the patulous eustachian tube. My experience, usually it's more the superior canal dehiscence or the third mobile window disorder. But another big one is otosclerosis. I actually had another patient this past week who has concomitant otosclerosis and superior canal dehiscence. Audiologically, it's usually pretty easy to distinguish the two in that, with otosclerosis, you've got absent acoustic reflexes with a normal tympanogram, and you've got a generally low frequency audiogram. This particular patient had that, but they also had very distinct symptoms of Valsalva-induced vertigo, and frankly, that was her bigger complaint, more so than the hearing loss. But on the CAT scan, you can see, she's got superior canal dehiscence, but she also had an otosclerotic foci right next to the stapes foot plate. So definitely had both problems. But I think the big distinction for clinicians is trying to make the distinction if they have one versus the other, not when they have both. Mm-hmm. If they have both, presents more of a treatment challenge, but the distinction on the diagnosis, I think, is the most important part.
All right. And I'm going to I had a list of questions, but that brings me to one question. This was actually from one of the clinicians that she's seeing patients, so she couldn't attend. But she had come to me some time ago and just said, I feel like I'm hearing these symptoms that sound like a dehiscence, but it's after procedures. And I remember Dr. Swallow saying, you'd be surprised of the risk, whether it's a cardiac surgical procedure, from sinuplasty to a eustachian tube to if someone has problems with cholesteatoma. Are there any, do you agree with all of those could potentially show up as some sort of a third mobile window syndrome, even though no one's looking at it? What we hear is, no, that didn't have anything to do with their symptoms.
Well, I think I would separate the types of surgery. Okay, first of all, surgery on the ear or even neurosurgical procedures, I would look at very differently than someone having a sinus surgery or a gallbladder out or those kind of things. Okay, now the non-ear, non-neurosurgical stuff, absolutely you can see third mobile window syndrome after that. But I think in most cases, it probably has nothing to do with the surgery per se. It has more to do with the anesthesia. Mm-hmm. In fact, for my patients with third mobile window syndrome, I have a pre-printed letter that I give them, and I think I have it in the book as well, that talks about what the anesthesiologist should do to avoid having problems or aggravating their third mobile window syndrome. For example, so let's say I have a patient, I've treated them medically for superior canal dehiscence, and they're doing great, and they tell me, okay, doc, I'm going to have my gallbladder out next week. I said, okay, here's a letter for your anesthesiologist. And the main things are, one, don't overload them with fluids, because one of the things the anesthesiologist is going to do is right off the bat, they're going to stick 2 IVs in and start pumping fluids in. And the whole concept for that is when you're in anesthesia school, they tell you once you induce anesthesia, your blood pressure is going to drop. So you want to make sure they have adequate fluids. And you also need to make sure they have adequate fluids in case the surgeon nicks an artery and there's intense blood loss right away. So that is a risk factor for aggravating third mobile window syndrome. Secondly, some cases they will, when they go to extubate the patient, typically they want to make sure the patient has very good control of their airway. So they wait until the patient's almost completely awake and their gag reflex comes into play. And they'll start choking on the tube and violently coughing, which can also aggravate their inner ear on top of having the extra fluid. And then third, when they get out of the OR, there's a high rate of postoperative nausea and vomiting from anesthesia, and you want to limit that. So I tell them to limit their fluids. I have them treat the patient like they're getting a craniotomy. So you want to lower their intracranial pressure, hyperventilate the patient, give them Zofran and whatever they need to do to make sure they don't have nausea afterwards. And I also have them do a deep extubation. And, so that the gag reflex doesn't come into play. And for the most part, I tell the patients, if you give this to the anesthesiologist, 99% of the time, they're going to say, oh, sure, we can do that. That's like doing a craniotomy. But if you don't tell them, they're not going to do it, and you run the risk of aggravating ear problem.
And that's great. And I do want to let our listeners know in the book, they do book, there's a chapter by Dr. Gianoli and Dr. Swallow where they shared, some resources from their clinic, which is great. So thank you for that. You've already mentioned this earlier on paralymphatic fistula. So you had an entire chapter on paralymphatic fistula, and at least maybe, lumping that into third mobile window syndrome. What would you like kind of take home points to be for our listeners on that?
So paralymphatic fistula is a condition that we know exists, but the actual diagnosis of it is very controversial. Who has it, who doesn't. In the setting of someone who's had stapes surgery, it's not very controversial. In the setting of post-trauma to the head, it's not that controversial, although it is a little bit controversial as to who has it or not. The question becomes in those patients who don't have trauma, don't have stapes surgery, can they have a paralymphatic fistula? And I think the answer is absolutely. And what it is often is cases where they've got abnormal communication to their inner ear via, superior canal dehiscence or one of the other dehiscences. In the case of someone who has all the third mobile window syndrome symptoms, has testing suggestive, but they have a normal CAT scan, that's someone that, as I mentioned, they either got a dehiscence that we haven't identified, or they've got a paralymphatic fistula.
Okay. There was actually several of them. Another one of the chapters I think it was chapter 14, was dedicated to visual manifestations post or related to third mobile window syndrome, with an emphasis on vertical hyperphorias. So what motivated you to we want to include a chapter on visual manifestations? Well,
so that's an interesting, very interesting topic, and something I'm interested in from a research standpoint as well. But it initially, what I would recognize with some of these folks is we would do their surgery, and afterwards they say, gee, doc, what did you do with my eyes? My vision is so much clearer now. And I'm thinking, well, I didn't do anything with your eyes, and it was one of these things where I figured, well, there's got to be some kind of vestibulo-ocular reflex, something going on that we've calmed it down and it's gotten better. And I didn't really think that much other than the fact that when they tell me that that's better, I know they've gotten a good result, and they generally do. Fast forward to, a handful of years ago, I started getting referrals from Dr. Debbie Feinberg, who's one of the authors of the chapter. And she's a neuro-optometrist who has recognized that patients with vertical axis misalignment, vertical heterophoria, that those patients, some of them have an ear source as the cause for their vertical misalignment. The most obvious one, they've got some kind of muscle abnormalities in their eyes that's preventing their eyes from lining up. But she recognized that in some of these folks, if they put noise canceling headphones on, it helps their vision, which was, is something that is still controversial in my field, but I've seen too many patients that have told me that this works, and I've seen it myself. They've also recognized that microprism lenses helps with the vertical axis misalignment and alleviates some of their symptoms as well. And so the theory behind it is when you have abnormal stimulation of the utricle. Well, if you think about what is the normal function of the utricle, the normal function is to detect gravity. And the reaction is if you tilt your head, you get this counter roll and the top eye goes down, the bottom eye goes up. Well, if you're getting abnormally stimulated, it's going to cause a vertical axis misalignment. And for the most part, if you think about third mobile window syndrome, the part of the inner ear that's most stimulated is actually the otoliths. We talk about superior canal dehiscence stimulating the superior canal, but what is a VEMP test? Mm-hmm. A VEMP test is a test of otolithic function. You use cervical VEMPs for the saccule, OVEMPs for the utricle. And so the problem is the symptoms from that are much more subtle, more difficult to define from the patient standpoint. And so they kind of fly under the radar. But the visual manifestations is certainly one of the things that we can see. And Dr. Feinberg goes into great detail explaining it in her chapter.
Yeah, it was very interesting. And certainly as on the therapy side, seeing, like a skew deviation, that vertical malalignment, it's kind of assumed central until proven otherwise. But it's certainly, I think, if someone's coming in with symptoms that sound, fall into that third mobile window syndrome, looking at a line, looking at ocular tilt, is there a pathological ocular tilt response? Certainly makes sense. I'm going to go backwards a little bit because the book, in the beginning does start with pathophysiology, but hearing you talk, it was so many great analogies from the coffee cup analogy. But I would like you, particularly because on the therapy side, we may not be exposed to it, if you could explain, because it is interesting that VEMPs that are doing otolith is catching a dehiscence on the canal side. Could you explain kind of how the pathophysiology of that?
Yeah, it's the pathophysiology is much easier to see in pictures. But if you think about what's happening, with the normal physiology of the ear, you're getting sound coming in through the stapes, and it's being routed up into the cochlea, and the output or the release of that energy is through the round window. When you've got the normal anatomy, the normal anatomy is the vestibular end is completely solid, so no sound's going to go in or out. Unless you have a dehiscence. Once you have a dehiscence, some of that sound energy will be shunted over that way, and the result of that is going to be stimulation of anything in its path. Okay, so for superior canal dehiscence, obviously you can stimulate the ampulla of the superior semicircular canal, but what's also in the way are the otoliths, the utricle and the saccule, and that's what we're measuring with VEMP. So it's basically a means of pressure, sound pressure getting transmitted another way. So the other part of it is intracranial pressure coming in. So if someone strains to increase their intracranial pressure, some of it can go through that defect and stimulate the vestibular end organs, provoking vertigo, dizziness, what have you. One point I should make is right now, we talked about the diagnostic criteria for dehiscence, and everybody's heavily leaning on vestibular myogenic potentials. I will tell you that they're great tests. Sometimes they're more sensitive than others, but they are not the all to end all. And one of the problems with VEMPs is, what if someone has developed a concomitant perilimb fistula and they have damaged their utricle and their saccule, and there's no response? Then the test is out the window. The other thing too is it has to do with the size of the dehiscence. There's a critical size. For example, one of the other classic things people like to point to is a low frequency conductive loss, but you need a certain critical size to get that conductive hearing loss. I'm reminded of one patient I saw, probably 10 years ago. She had originally presented to the doctors with complaints of third mobile window syndrome. She had calorics and she had VEMP testing at the time. The calorics were normal. The VEMP testing was abnormally sensitive, kind of confirming she had a third mobile window syndrome or superior canal dehiscence. 5 years later, she gets calorics and VEMP testing repeated. At that point, she had a mild caloric weakness in the ear, the suspect ear. The VEMP test was still abnormal, but not quite as sensitive. It was like the first time her C-VEMP was maybe positive at 65. Now it's at 70, 75. 5 years later, she comes to see me. We repeat calorics and VEMP on her. At this point, her calorics show a big time weakness, like 50% caloric weakness. Her VEMP testing is quote unquote normal at 105. And I submit to you in this particular patient, that's an abnormal VEMP given that she's lost 50% of her caloric response.
Yeah.
I saw another patient recently who presented like a vestibular neuritis. And every test you want to run on this lady was absent. She had absent calorics, rotary chair, her gains were down, big asymmetry. She had her V hits were off on that side, but she had normal VEMPs. And she had a superior canal dehiscence. And so she was kind of written off as a as a vestibular neuritis, but she would still get episodes of vertigo and she would strain and blow her nose and things like this, to the point where it obviously wasn't the right diagnosis. And we did surgery on it. She did great afterwards.
That's an interesting point. I saw a patient last year that presented as Meniere's. She actually had a conductive loss, though not a high sensory neural. And she would have Meniere's-like attacks when she would be near this big copier where the kids would go through, and she would lean on it, and if anything was doing it, she would have a Meniere's attack. But then, so we were asked to do VEMPs, and her VEMPs were normal. And then what we got back was, well, that's why we can't rely on VEMPs. They really don't tell us anything, because this is someone with Meniere's. But then someone ordered a high-res CT scan on her, and she had a very large semicircular canal dehiscence. Yeah.
Right. Well, the whole subject of Meniere's or endolymphatic hydrops is another thing that I think is a topic that needs to be brought to the forefront. I've seen a ton of patients with classic Meniere's syndrome that have dehiscence. And I have an interesting, I just did a presentation on this, where a patient of mine who presented with just classic Meniere's syndrome, she was treated like she was a Meniere's patient, wasn't getting better, and came to see me. This was in year 2012. And at that point, we did her testing. Her VEMPs were present. C-VEMP was present at 65 decibels. She had a caloric weakness in the ear. She had a low frequency sensory neural loss, not conductive. And her CAT scan showed a big dehiscence. So she was not responding to medical therapy. And the one big thing I added to her is I told her, stop straining. Her symptoms all went away is once she stopped straining. We also increased her diuresis, and she was fine until the year 2022. And in April, about a year ago, her hearing dropped out big time on this eye. And she didn't have vertigo yet, but then the vertigo came. And so eventually she came back because the vertigo was just untenable, and worked her up again. Her testing was even more demonstrative of a superior canal dehiscence, and we did her surgery. That was about 3 months ago, and she's been free of vertigo since.
Oh, wow. Speaking of that, I know this is probably a pretty unfair, I don't know if it's a loaded question, but you do have a chapter on here on medical management, which I remember originally when dehiscence started. I can't remember if it was also Dr. White at the Cleveland, not sure, I can't remember, but surgery was like, you've got to do surgery. And then it became this more conservative approach. Medical management I guess it varies with every patient, but I'm going to go ahead and ask, is there some kind of threshold where you prefer to go conservative management and then say, we have to do something more aggressive or a surgical? Is it just when it becomes unstable?
Well, I personally think it's hard to say there's a general rule for everybody. But in general, I like to start with conservative stuff. And my rationale behind that is, even if only half of the patients get some benefit, that's half of the patients that don't have to go through surgery and don't have to go through the risk of surgery. And because there's risk associated with this surgery. It's not an insignificant surgery. The other thing is, I find after doing this now over 25 years, is that the patients that get medical management do better when they do have surgery. Mm. And they have a lower chance of recurrent problems down the road. One of the things you'll hear about is there's a lot of folks out there that have had superior canal dehiscence surgery, yet now they've got hydrops, yet now they've got this and they've got that. And I would argue that these are some of the folks that they've not been given any kind of medical management.
And so is that the medical management again? And here you talk about that something very similar to Meniere's. Well, I mean, there's lifestyle, maybe a diuretic, kind of the same approach.
Yeah, well, let's talk a little bit about hydrops. Okay, so there's a lot of studies coming out, and I mentioned my clinical experience with it, but there's also studies coming out showing MRI evidence of endolymphatic hydrops in patients with superior canal dehiscence. Mm-hmm. And the incidence is anywhere from 25 to 80%. I think it's part of a spectrum of disease, going from asymptomatic, mild, kind of minor syndrome where you get these short little spells, to third phase where you get full-blown Meniere's type stuff. And then the last stage is when they've basically blown out their ear. They've got almost no function left in it. But I think all the stuff we used to do for Meniere's patients is worthwhile looking at for treatment of third mobile window patients, and including the diuretics. I personally like acetazolamide because it lowers intracranial pressure better than the plain diuretics. Diet, avoidance of straining. And then the last part of the medical management is looking at other medical problems that can cause increased pressure, like sleep apnea and those kind of things.
And I do want to come back to that, because I have that's kind of the sleep apnea was my awakening to superior canal dehiscence from Dr. Swallow. We do have a question. Are bone vents more sensitive than air conductive vents at identifying a dehiscence of a smaller size?
Well, I'll be honest with you. We use air on all of it, so I don't have much experience with bone. My understanding initially, OVEMs were more sensitive when using bone conduction, but I don't know the answer to that.
Okay, let's go back to the sleep. So you've written articles, published some papers that there is a high correlation of third mobile window syndrome in people with obstructive sleep apnea. And so do you want to elaborate on that? Or I would even think, like, as clinicians, as healthcare providers, should we be, if it's kind of like when someone comes in and says, I have this symptom, we don't want to just stop there. We're not just collecting information to collect information. It's like, what is that giving us a clue about? What's the most likely? What's the most serious? Is there a prevalence between third mobile window syndrome and obstructive sleep apnea?
Yeah, that's a great question. And as far as prevalence, I don't know what the prevalence is, but I can tell you that obstructive sleep apnea is a very common problem. It is one that's kind of flying under the radar, but it is linked to hypertension, early heart attack, strokes, etc. And we have witnessed, Dr. Swallow and I, that there's a number of folks, excuse me, that if you treat their sleep apnea, their ear problem gets significantly better. Now, there's a number of theoretic links to why that is the case. I actually just reviewed an article from one of the journals where they were proposing that it was due to low oxygen level getting to the brain and causing some issues with dizziness there. I personally don't think that's the case. I think it's high carbon dioxide level causing cerebral vasodilation and increased intracranial pressure causing issues. And I suspect that mainly because of patients, we've done a number of lumbar punctures where you can see there's a lot of benefit when these patients get their CSF pressure drained immediately. And it's like night and day. They come in feeling lousy, they leave feeling great after they've gotten spinal fluid removed. I've had a number of folks where we've done lumbar punctures on them, and we will get two measurements for the opening pressure. The first one is, and I don't do the lumbar punctures, I refer to an anesthesiologist that does it. So they're in a recovery room setting. They've got oxygen monitored, their EKG monitored, the respirations monitored. They've got the anesthesiologist and the nurse anesthetist there. And so they will sedate the patient. They'll get an initial reading with the patient sedated, and then they'll wake the patient up. Okay, take a few deep breaths and wake up for us. And then inevitably the pressure will drop. And which is the opposite of what a lot of my clinician friends would say. They would think, oh, it must be higher because they're going to tense up, and I'll know. And the big difference, I think, between the two is reduced respiratory rate. When we have a lower respiratory rate, our carbon dioxide levels will go up. And when you increase respiratory rate, it goes down. And it is one of the most amazing things you will see is what happens to intracranial pressure, and it's fast. It does not take long. As a matter of fact, if you show up in the ER with a head injury, first thing they're going to do is they're going to intubate you and hyperventilate you. And the reason they're going to hyperventilate you is to lower your intracranial pressure. So I think that's the big link between sleep apnea and third lobar window syndrome. It's the change in intracranial pressure. There's a number of papers out there that show intracranial pressure in sleep apnea patients is much higher at night than it is during the day.
And obviously, I won't get us off track, but I could spend an entire day talking about increased intracranial pressure, idiopathic, all the correlations is people with retention problems, glaucoma, increased third mobile window syndromes. I think we're going to hear more and more about that in the future. I do want to leave some time for some questions. I want to ask, before I address the questions that have already been sent in, and this is a brand new book. It came out in January or February. But
in February, yes, ma'am.
Is there, even when you think about this book, is there like a chapter that you see adding in the future that your wheels are already spinning?
You know, there's a lot of things that I think need to be talked about. Problem is the research is not there yet. That's the problem. You know, and one of the things, and I make this very explicit in the medical management chapter, there is no research on medical management of superior canal dehiscence. That's all basically my personal experience of dealing with it. That's something that I really think we need to explore. There's a number of other things. The psychiatric aspect is another part that I think really needs to be explored. There's a lot of folks that are labeled as having, PPPD that have superior canal dehiscence or other third mobile window disorders, and I'll be honest with you, I hate the whole label thing, because a lot of times once a patient gets a diagnosis, clinicians stop thinking, oh, they've been diagnosed with this, we don't need to think about anything else now, we just treat this. And a lot of times, it's not necessarily the correct diagnosis. So if the therapy isn't working, you need to kind of rethink, do I have the right diagnosis?
Yeah, and I think I'll kind of leave your diagnosis at the door. Cognition is talked throughout this book, and which was I really appreciated. And then there's 3 chapters on the patient's perspective. At least one is like, asking you questions, what a Q&A with you, the importance of the patient-doctor, communication, and then just what it's the patient's journey. I mean, 3 chapters are associated with that, which was inspiring and meaningful.
Yeah, that's in a lot of medicine, the patients will come in and tell you what their problem is. What we have here is all of them come in, they say they're dizzy, but it's like, that's not real helpful for me. In the past, traditionally, it's been, describe what you mean by dizzy. Is it a spinning feeling? Is it lightheaded? And even that's of somewhat limited utility. I mean, if they say they're spinning, you can be pretty sure they're getting semicircular canal stimulation. Beyond that, it's not a whole lot more helpful. There was a study done, I apologize, I don't remember the names of the authors, where they looked at an alternative way of getting history, which is looking more at the triggers or the exacerbating factors. I personally think that is a much more useful tool for history and helping to figure out if someone's got an inner ear disorder or vestibular disorder than not.
Absolutely. Okay, here we go. We're a marathon of questions here. You already actually addressed one, how to choose between medical and surgical management. This one, as a vestibular therapist, I've questioned whether or not to ask the patient to perform VOR exercises. Even if the patient is medically stable, do you think VOR training is a contraindication?
You know, I think contraindication is kind of a strong term, if you ask me. You know, I don't think it ever hurts to do VOR training. Now, the question becomes, is it helping? And the most utility, obviously, in someone who's got a stable vestibular loss. Those patients are going to do fabulous. The problem with third mobile window syndrome is it's inherently unstable. Now, once they're stabilized, then, you know, vestibular rehab therapy does phenomenally good. So my approach is often, a lot of times I see patients, they're ongoing with vestibular rehab therapy and they're not getting better and they've been doing it for a year, and it's like, okay, stop. Let's get you stable, then we go back to therapy. And so the whole concept I try to emphasize to them is the whole idea about therapy is you want to get your brain adjusted to this new level of functioning, but we got to get the function to be stable, because if it's fluctuating, you can do this for 10 years, it's not going to matter. The other thing I think is real, and just a point I think is worthwhile making that is very obvious, but in all of us who deal with patients with vestibular and balance disorders, the number one thing we should do is be counseling them on safety. And it's, you know, even if we don't do anything else, that is the number one thing. And almost every one of my patients, I tell them, look, this is not a life-threatening problem unless you fall off a ladder, get in a car accident, or something like that. So number one, you want to be safe and don't let pride go before the fall, so to speak. That's number one. The second big one, I would say, and this is right going up with the therapist, is lower extremity strength. I can't tell how many patients I see that they've got this much vestibular problem, but their lower extremities are so weak that it's like, I don't care what I do with their ears, there's still going to be a fall risk. And, you know, so I make the big point is I want you walking every day. And some of them I will encourage, you know, especially some of the ones less motivated, I'll send them to therapists just for lower extremity strengthening, just training to get them to beat on them, so to speak. Work, it's got use it or lose it.
Yes, exercise is the best medicine. Can medical or surgical options for third mobile window syndrome benefit someone with an unmanaged sleep apnea?
That's a difficult question. You know, it depends on how bad the sleep apnea is. I mean, just like everything else, there's degrees of it. I will occasionally get patients with really, you know, I'll do sleep studies on some of these folks if I'm suspicious of the intracranial pressure problem. And some of them have very mild sleep apnea. Those, I don't think it really makes too much of a difference. I'll usually send them for something other than CPAP. I'll send them to see an ENT doctor about maybe getting their nose fixed or a mouth guard or something to help with that's, you know, because so many people hate CPAP.
Right.
On the other hand, if you've got somebody with really bad sleep apnea, I think it's an uphill battle to try to make those folks better. I mean, it's not impossible, but
right.
Yeah, it's difficult.
And I'm going to be selfish here and ask a question. Is there any level on a sleep apnea, a CPAP machine that you think is of concern because of the high amount of pressure it's delivering?
You know, that's a great question. And, you know, I don't know the answer to that. there's been some papers out suggesting that CPAP can cause a fistula. I personally wonder about it, because here you got a group of patients where they got high intracranial pressure. They're at risk for a fistula, and you're doing something to treat their sleep apnea, which theoretically should make it better. But is it because of the CPAP, or is it because of their underlying disease? I don't know.
Okay. So, all right. Is flying a problem?
I think flying can be a problem with patients who have eustachian tube, borderline eustachian tube function, or bad eustachian tube function. In most cases, if they've got normal eustachian tube function, they don't have any trouble with pain in their ears when they fly, they'll probably be fine. But there's a significant subgroup of patients where flying is a big risk. And actually, if you read Philippa's book, that's when she had her first episode, was on a plane, which is not unusual. I've heard that from a number of patients. The problem is many of these folks don't have any trouble at sea level. It's not until they go on a plane that they realize they've got eustachian tube problems.
Gotcha. I actually know the answer to this one. Is there an ebook available? And so there is an ebook available, and I am actually going to release an offer. If you click on it, it will open up in a new window. But Dr. Gianoli and the publishers have been kind enough to offer, almost for a month, a 20% discount off the book, the hardcover, or the actual ebook. And I'll make sure when I post this video that I also upload the PDF for that. Okay, so we'll be wrapping up, but I have another question, and then I'll be looking for some more questions. I'm a PT. I've seen several patients with SCD-related symptoms. I've already mentioned this one. After cardiac stent surgery, different surgeries. So I asked that one earlier.
The other one I'd throw out there is after vaginal deliveries.
Yes.
Real big common one. After so the running joke Jim and I would, it's this all started. How long have you had this, ma'am? Oh, this all started just about the time I started that Pilates class. And they never put the two together. It's like, that's when I go into my Groucho Marx mode. Doc, it hurts when I do this. Don't do that.
Yes, don't do that. Yeah.
But after vaginal deliveries, real big, general, and with surgery, it's general anesthesia. If they're having something done under sedation, it's usually not a problem. Now, we mentioned ear stuff. Totally different situation. Some folks will get PE tubes placed. And the reason they're getting PE tubes placed is because they've got fullness in their ear, and they get misdiagnosed as having eustachian tube dysfunction. Or maybe they actually do have eustachian tube dysfunction, but it's not causing their, third mobile window syndrome.
Yeah, we do see that. Well, thank you so much. We're right up on the hour. I don't know if anyone wants to throw in any additional questions, but I'm glad we finally got to do this. And then I'm gonna be with you again June 3rd. You're going to be serving on the expert panel for our advanced vestibular class or course. And then in October, we're going to be doing a conference where you're going to be our keynote on the business of balance. And I can't wait.
I'm excited too. Thank you for having me. I appreciate it.
Yeah, and I will be in touch. And I want to thank everyone for participating. And for those of you, I told you, Dr. Gianoli, you could jump off. I'm going to go over a couple of other things regarding our company, 360 NeuroHealth. But I really appreciate it.
Thank you so much. Y'all take care.
All right. So Dr. Gianoli he's left the room. And then I am going to share some slides because, well, I'll start with the sad news, and then I'll end with some Good Friday news. Jessica, the other co-founder of 360 NeuroHealth, the one that brings all the exciting ways to deliver content to you, is not able to be here today. She is not feeling well. And so we are going to postpone some things that we wanted to announce that she's been working diligently on. I'd like to go over some exciting updates with 360Neuro Go. We're going to reschedule this for next Thursday evening, and we'll have some more updates and exciting offers for you. But you just heard me mention the advanced decision-making course that we have coming up. It's online through the month of May. And then you can attend the lab. It's a day lab on June 3rd, where you can do it virtual or come to Austin before it gets too hot and enjoy a Saturday here. So we're super excited about this course. This is just a snapshot of what it's going to be like. We're going to kick off. I'm going to be actually with another therapist. We're going to be laying down the foundation of this whole thought process of the discussion on heuristics. Heuristics is a term that has historically been used in psychology, and it's how we take shortcuts without it's not considered the easy way out. It's using our knowledge, right? We're all so much content, and how we can use it to quickly, efficiently, and accurately through deductive reasoning and decision making come up with ideas of a working diagnosis. What's the best test? What are my top three? What are my top three questions, my top three tests, my top three treatments? And this is not only to optimize outcomes. This is a mental, intellectual process, not to only serve our patients, but us as well, because we know in many chronic patients with chronic symptoms, there can be quite a mental toll on us as providers. And so what we want to do is be able to take these concepts and be able to use deductive reasoning to guide us through our treatment. So Fred and I are going to kick off that. You'll have some assignments around it. And we have Tuesday evenings where it's live. You have some assignments. And then on Saturday, I'll be available on Saturdays. I can pop in through 360Neuro Go, answer questions, but it's kind of at your own pace where you complete some assignments. That second week, we're going to talk about the psychological manifestations. We'll actually be working with a psychologist, and we're going to do some role playing. And I know I'm selfishly going to take advantage of that. I already have taken advantage of that in coordinating that series with Dr. Capello. Is something that I have experienced, even a case I experienced last week, of what could I have done differently? What can I do? What can I do better next time, both for myself and the patient? How can we effectively manage if someone is, perseverating on doom? And it's not just a matter of, are we asking the right questions? It's starting with, we're going to call them yellow flags. Someone comes in, they check anxiety, they check depression. We don't just collect those symptoms. What's our next step? So we'll be sharing some, guidelines. And then it's like, okay, now I'm in the eval, and I'm asking a question and I'm getting an answer of doom, or the answer is not matching my question. How can I redirect? When do I stop? Maybe it's time for me to stop. So he's going to help us work through some role playing based on what we face with some of our patients. If you plan to attend this course, or either way, we welcome the discussion on this. Share case scenarios that have been troublesome to you, because that's what it's about. How can we quickly redirect our own thinking? Because if they're frustrated and now I'm frustrated, how can we stop that cycle? How can we turn this situation? Can we turn this situation around? I did the whole 0 to 10. 0 is none, 10 is the worst, and every answer was 18. Is it time to go to the emergency department then? What kind of verbiage, what kind of language can we use to make it effective for both ourselves and the patient? The next week, we're going to be working with an audiologist to talk about neuro-otologic manifestations in vestibular rehab and some key things to look for. We're going to be working with a manual therapist the following week about musculoskeletal manifestations in vestibular disorders, and then with Dr. Fitzgerald that final week on visual manifestations. And then the lab will be case studies, group case studies. It doesn't matter if you're here in person, if it's virtual, we're going to work together. And then ultimately you will present as a group your case to a panel, an expert panel, which will be Dr. Gianoli, Deanne Fitzgerald. We'll have we have an audiologist on the expert panel, and we also have a psychologist. Dr. Breen, who I had mentioned earlier, is also going to be helping facilitate the problem solving process. And in the afternoon, we will continue to wrap things up after the expert panel. And the goal is that we can all go away with what would help you in the clinic with these shortcuts, with these heuristics, with these clinical decision-making kind of at your fingertips that will come together as a group. So I'm super excited about it and hope that you get to join us. And if not, we will be doing this, course again. And then we have next Thursday, we have some exciting announcements. We're going to be launching our new website, our option for 360Neuro Go Enterprise. So details are coming soon for that. That will include a pretty insane amount of educational opportunities with that, and just some new features we have with 360Neuro Go. So next Thursday, we have it on the event calendar within 360Neuro Go that will be reviewing some of this and telling you about some of our new features. And then you heard me mention in October, we're going to have the business of balance and dizziness. And this isn't just to talk about how to go, this isn't a how to go make money. There is a business part of this, but the need, we know there is a great need across the lifespan, across, from pediatrics to geriatrics, from acute care to outpatient, to multiple disciplines. Patients with dizziness and balance disorders, from concussion, come from so many different, what we would call specialties. So this is about how we bring in vision, how we bring in vestibular, concussion, cervical across all these patient populations. And we'll be talking about some pain points too. We'll be reviewing, billing. Maybe billing is a pain point for you. Maybe it's how to get doing the HINTS test consistently in the acute care and the importance of that across the setting. So super excited. Dr. Gianoli is going to kick that off as our keynote, and I'm super excited about that as well. So that is I'm going to wrap it up, and then I hope that you can join us next Thursday evening, and Jessie will be better, and she'll be feeling great and be able to join us. So thank you all so much. If you have any questions, please let me know. You can always afterwards, you can still ask questions in the comments section. This will be uploaded with the handout for the coupon for Dr. Gianoli's book as something that you can print out regarding the coupon if you didn't get to go to the link and access that when I released it earlier. As always, thank you, and hope to see you soon.